Good evening, all. Myself, Dr. Kanaram Patel. I welcome all of you on behalf of Glenmark. Hope you and your dear ones are doing well in this COVID pandemic. So, coming to the today's webinar's topic, as the COVID pandemic is evolving, the measures of its management are also evolving, and we need to rationalize every treatment, every prevention measures from the perspective of current trend of pandemic. In current phase of pandemic, major chunk of COVID-19 patients are from OPD or outpatient department. In today's scientific session, we will highlight the role of oral antivirals in the management of COVID-19 outpatients department. And to discuss the same, we have a pack of eminent panelists. With us, we have Dr. Paparao Nada Kuduru. Sir is a senior consultant physician and head of the department internal medicine, KIMS Hospital, Hyderabad. Welcome, sir. We also have Dr. Inder Mohan Chuk. Sir is director and head of the department of interventional pulmonology and sleep medicine at Max Super Specialty Hospital, New Delhi. Namaste. And we have Dr. Zenith Sinojiya. Sir is consultant critical care medicine at Sterling Hospital, Rajkot. I welcome all of you, sir. And to moderate our today's panel discussion, we have Dr. Sagar Bhagat from our Global Medical Affairs Glenmark team. Before we start the panel discussion on the role of antiviral in the management of the outpatients COVID-19, I want to take you through the highlighting parts of the oral antiviral we have, like Favipiravir, molnupiravir, and how was the experience with this molecule and how is the efficacy and safety data of this molecule perspective of this current pandemic wave 3. So through this presentation, I'll highlight the data of the Favipiravir, how it is efficacious and safe, what is the body of the evidence, how many published articles are there, and apart from that, I also highlight the current wave and how Omicron is playing a different game. Favipiravir versus other oral antiviral, including the molnupiravir, some safety concerns of the molnupiravir, and finally how Favipiravir is an experienced oral antiviral in COVID-19 management. To start with Favipiravir, the Favipiravir has robust data, including the phase 3 post-marketing trial, real-world evidence. So for the regulatory approval, the phase 3 study was conducted in India. It was conducted in 150 patients. And the results are like the time to clinical cure was just 3 days in the patients who have taken the Favipiravir. The viral clearance in 1 week reduced in 2/3 patients of the Favipiravir group. The viral clearance was 30% faster compared to the standard of care treatment, and there was no discontinuation because of Favipiravir treatment, and there was no unexpected AE were reported in this phase 3 study. After the successful phase 3 study and the marketing authorizations, as per the regulatory standards, the post-marketing study was conducted, and it was a large prospective study for the COVID-19 treatment. Almost 1,000 patients were recruited for this trial, and the fever resolution was seen within 4 days. The clinical cure was within 7 days. The oxygen requirement from baseline to end at the end of the treatment reduced 98.6%. The overall adverse event reported was 12%, but point to highlight that only 1% were related to the Favipiravir drug. And whatever the side effects or adverse event reported, most of them, 90%, were mild category. So again, with this post-marketing study, the safety and efficacy established in the management of the COVID-19 patient. After the, we not stopped with the post-marketing study also, we have conducted multiple real-world evidence studies in mild patient, in moderate patient with high-risk categories, patient with multiple comorbidities. So this study was conducted in mild COVID-19 patient at 4 centers across India, and the median age of these patients were 50 years. There were hypertension patients, there were patients. The biomarkers were raised at the baseline. The symptoms were fever, cough, myalgia, and fatigue. And you can see The time to cure in terms of the resolution of the baseline symptom was just 5 days. So it took only 5 days to resolve all the symptoms. The requirement of the oxygen is reduced by 95%. So it was found effective in mild patients. Not only in mild patients, the study conducted in the high-risk patients, those who have one or two comorbidity. So among 350 patients recruited, the studied in this study, 120 were more than two comorbidity. The the dyspnea was higher in the patients who have more than two comorbidity. But when we compare the efficacy of favipiravir in group having one comorbidity and having a two or more than two comorbidity, the effect was same. The symptom improvement was seen by day 7 was similar in both group. The improvement in clinical signs by day 10 was similar in both group. The requirement of oxygen reduction was similar in both group. The patient having one risk factor and patient having more than or equal to two comorbidity. The protection against the disease progression was also similar in both groups. So irrespective of the number of comorbidity, favipiravir was showing similar effect. So these are the some studies conducted in real world patients, and not apart from the studies in phase 1 and wave 1 and 2, the favipiravir has given to the more than 5 million patients, and these patients are benefited by the faviplu treatment, that is favipiravir. This data is published at national and international platform, and we got the appraisal for this. And this data is also published at many international journals, including the World Micro Forum, the KPSR, then the ERS International Congress. This was regarding the wave 1, wave 2. Now the wave 3 is predominantly uh, because of Omicron. How it is different from the previous variant like Delta. So we are in this slide, we'll highlight the difference between the Delta and Omicron. Both require the ACE2 receptor protein to enter inside the human cell. But the difference is Delta recruit TMP-RSS2, again the host receptor for the entry into the human cell. But Omicron doesn't require it. It recruits the endosomal pathway. It doesn't form cells in sinojiya. Secondary attack rate, that is the infectivity rate, is higher in Omicron, we all know, and it is almost double the Delta infection rate. Symptoms in Delta infection were high fever, loss of smell or taste, myalgia, and fatigue. But this loss of smell and taste is not commonly seen with the Omicron infection. The lung involvement was very common, not common, but more than the Omicron infection. The COVID-19 severity was higher in the Delta infection. There was increased risk of emergency care, hospitalizations, oxygen requirement, and ICU admission and mortality. But the severity in Omicron infection is 29% lower than the Delta infection. The hazard ratio is 3.7 in the Delta and it is 2.1 in the Omicron. Now, talking about the treatment of these two infection, the antibodies and oral antivirals were found effective against the Delta infection. But in case of Omicron, antibody cocktail or even the antibodies of the vaccine are not found effective against preventing the Omicron infection or treating the Omicron symptoms. Now, so only the option remains is the oral antiviral like favipiravir, molnupiravir, and Paxlovid. Either favipiravir or molnupiravir are effective in Omicron infection. So this Kemrar group, that is a biotech giant, the scientists from this group, they announces that the favipiravir is effective against the COVID-19 variants, including the Delta and Omicron. And the rationale is that the favipiravir acting against the RNA-dependent RNA polymerase, and this protein is highly conserved. This is highly conserved protein. This is not that protein that get mutated. So this is resistant to the mutations, and till the RDRP is there in the SARS-CoV-2 virus, favipiravir will be effective against that any variant of the infection. So if we talk about the proportion of the Omicron and Delta infection in India, so the data suggests that Omicron infection dominating in India, almost 75% cases are of Omicron, but Delta has not yet gone. 20% cases are still of Delta variant. So, what are the treatment options are available? I said, only oral antivirals are effective against the Delta and Omicron infection. So, how their efficacy is safety against the Omicron and Delta? So, if we compare the Favipiravir and molnupiravir, both are oral antiviral. Both are acting against the RNA-dependent RNA polymerase, but there is slight difference in the mechanism of action. Favipiravir, where it terminates the protein synthesis and it prevents the RNA replication. Molnupiravir mainly mutate the RNA, and whatever the virus newly found, they are non-functional. They are not viable. So basically, mutation is the part of the mechanism of action of the molnupiravir. The prior experience with the Favipiravir use is very good in India. In wave one and wave three, wave two, this Favipiravir has used extensively. So there is a known safety profile with the Favipiravir. But when we talk about the molnupiravir, the safety profile is still being explored. Indication for the both molecule are same, but molnupiravir is restricted in high risk patients only. Safety concern with the Favipiravir is not much that, but the mutagenicity, the teratogenicity is labeled with the molnupiravir. The contraception required after the last dose of the molecule in case of Favipiravir is 7 days, but it is 3 months, that is 90 days in molnupiravir. The clinical evidence with the Favipiravir is more than 5,000 patients, but the phase 3 study conducted by the Merck and the phase 3 study still being continued in India is the conducted in patients 3,000. And the experience of physician with the use of these two molecules is highly different. So almost 5 million patients in India are benefited by the Favipiravir, but the experience with the molnupiravir is it just launched now, so there is no much experience with the use of molnupiravir. Coming to the efficacy, the phase 3 study conducted with the Favipiravir and molnupiravir, I have mentioned here. So the parameter used in the phase 3 study of the Favipiravir was the clinical cure rate, and the parameter used in the molnupiravir study was the clinical improvement. And you can see the difference in the numbers. The higher number of patients are clinically cured in the Favipiravir, and less number of patients were clinically improved in the molnupiravir study. The median time to clinical cure was 3 days. The time was 3 days compared to molnupiravir, where it took 8 days to show the clinical improvement. This is the interim analysis of the Indian phase 3 study conducted by the Hetero. Talking about the disease progression, the median time for the oxygen requirement in Favipiravir group was 5 days compared to 2 days in the control. 1.4% only patients required some form of the oxygen therapy. While talking about the molnupiravir, 6.8% patients in molnupiravir group required hospitalization, or some of them succumbed to the death. There are some concerns, as said in earlier slide, like the carcinogenicity, mutagenicity, and the teratogenicity. And FDA is saying the same. The FDA concluded that 5 days treatment of molnupiravir has low risk of genotoxicity. The animal carcinogenicity study is still undergoing, and we may come up with the new data of the safety of the molnupiravir. The Infectious Disease Society of America is saying the same, that it should be restricted in the high risk patient only, not should be generalized, not should be given in all patient of the mild moderate category. Talking about the Indian body, that is ICMR, they are also against the molnupiravir recommendation. The task force, the COVID-19 task force, National COVID-19 task force, the meeting held on the 12 January, they concluded that there is a rampant and irrational use of the molnupiravir. There are known and unknown harm of the molnupiravir, and it shouldn't be included in the national COVID guideline. It the indication window is very narrow for the molnupiravir. Experts haven't observed any benefit among patients with the diabetes, those who have the recovered from the COVID-19, and those who have been fully vaccinated. If we see the recommendation by the national and international guidelines, the Russia is continuing mentioning the Favipiravir in their national guidelines. Now they are also included. They have also included the molnupiravir. In India, the government of Maharashtra task force have included the Favipiravir in their guideline, the state guideline, and also the molnupiravir. But it is the use of molnupiravir is restricted in ANC, PNC, and prospective mothers. Prospective mothers. This is the concluding slide. Favipiravir has established its efficacy, its safety profile through multiple studies, almost 26 clinical studies in 14 countries in more than 6,000 patients. It is RDRP inhibitors. It is repurposed drug, has undergone robust development program, and overall well-characterized safety profile is there. So we can say it is an experienced oral antiviral uh, drug in COVID-19 management, which is standing still in the against the Omicron infection also. So thank you for patiently listening the presentation. Now I'll hand over this session to our moderator, Dr. Sagar Bhagat. Over to you, sir.
All right. Thank you. Thank you so much, Dr. Kanara, for taking up the presentation, for taking us to the data that is available with the available two oral antivirals associated. Now, what I'd like to invite our experts, Dr. Paparao sir, Dr. Inder Mohan sir, Dr. Zenith sir, to head the much awaited panel discussion scheduled for tonight. To start with, I would like to ask Dr. Paparao sir, much has been talked about the current wave, and whenever we always have this tendency to compare the current wave with the one that we have already faced. When we were going through the second wave, the Delta variant, we did compare and said that the Delta wave was really good than compared to the first wave. So I just wanted to have your experience that the current wave, what are the common or the uncommon presentations, or how the current wave look to you? Is it same as that of the previously two seen, or there is some difference that you have been experienced?
There's clearly a lot of difference. Number one, the presentation now is more of upper respiratory infection like nasal congestion and throat congestion. This is commonest. And they have mild cough, mild fever, and body pains. And anosmia, it is happening, but it is not as common as it was in second wave. But the rare presentations are like they have some of the people are presenting with diarrhea, which is also one of the common, but rarely they are being presented. And this taste, some people differently have not seen even in second wave. They are presenting that the saltish taste, once they feel, when others feel it is normal food, but they whatever they eat, they feel the saltish taste. And beyond all, the most common symptom of all the people is they are not able to believe that they have COVID, because they are in a denial mode and they feel this is not COVID because the symptoms are so mild, and they don't accept that they have COVID. But everything is taken care that and they are guided properly to go through. And of course, once they see the test, they will believe, and it's going like that.
Right. So in continuation to this, you said that most of the patients are still in the mild category.
90% are very mild category, right. and they have only congestion, nasal symptoms, and mild fever for 1 or 2 days, which they have forgotten. And body pains are also very mild compared to earlier. Earlier, we used to find a lot of cough, very high-grade fever is continuing, and unless there is an active treatment, there is no relief in earlier second wave. But here, most of the times they find they are fine, and somewhere they will go and get checked, get tested for either antigen or RT-PCR. Once RT-PCR comes positive, then most of them, they are coming back to us for opinions and advices. That's going like that.
All right, sir. Dr. Zenith, sir, in continuation to what Dr. Paparao has just highlighted, that the presentation what we currently see in this wave is more of a mild, and some very rarely we come across a severe presentation where lung involvement is highlighted. But going back to the data, we have seen that age and associate comorbidities, these were some of the important risk factors for disease progression. So even if the patient in the current wave we have seen that belongs to the mild category, how do you feel that these two risk factor, age and comorbidities, do it plays the same important role in the current COVID-19 cases?
Sir, as Dr. Paparao has said that the cases are mild, but all the game revolves around, I think, the risk factors. So the one who had the risk factors, that like age more than 60 years is a known risk factor. Then diabetes, hypertension, heart disease, cancer patients, and your kidney and liver chronic patients. These are the patients. They are the ones. The as sir said, it is a 95% are the normal infections, but that 5%, probably this 5% will belong to the ones who have these risk factors, and probably they will be succumbing in even this even in the Omicron wave. They are the ones who will get the disease more severe disease, and the disease which required hospitalization, and it will require the ICU. Probably these are the ones who will get this. So the risk factor will even play a very good role in this particular wave also.
Okay, sir. So in case from this point, if I want to take home one message, that age and comorbidity, these are still the risk factors and need to be
Yes,
considered
exactly.
while treating, whether it
Yes.
even if it is a mild case.
Yes, even if at the beginning everything will look mild for everybody, but
Correct.
probably the ones who have the risk factors, you have to be more cautious. They are the ones
Right.
who need a more frequent monitoring, biological, like biochemically, or like CT scan or whatever ways, and they are the ones who may or may not require the indoor treatment.
All right, sir.
So
Good
it is
point taken.
all about risk factors. Yeah.
All right, so point noted. In the motion, one of the slide presented by Dr. Kanaram, the overall Indian data just about the distribution of the two variants what we currently see. No doubt Omicron has overtaken the previously seen Delta variant. One of the data highlighted that there were still around 25% of the Delta variant still we currently seen in India. So first, I would like to ask, how is your practical experience? And in continuation to that, there are still 25% data that was highlighted of Delta variant. So what clinical pearls would you like to suggest in optimizing this care?
See, as discussed earlier, Omicron symptoms are basically URI, and majority of the patients are managed on the basis of OPD basis. But few patients with Omicron with comorbidities have been hospitalized. But as far as what we have learned from first and second wave was predominantly. So I would like to add 4 or 5 practical points which are useful for clinical practice in the management of especially Delta variant or severe COVID. So first you classify the patient into asymptomatic, mild, moderate, severe and critical disease. As we all know, asymptomatic and mild patients are treated best in home isolation, and moderate to severe and critical patients are hospitalized and admitted best in a hospital setting, in the ward or in ICU as required. So antivirals are very useful. Oral antivirals like Favipiravir and molnupiravir. Then if the patient is hospitalized, we have remdesivir, and in addition now baricitinib, that is a JAK inhibitor, that is also required. Then most importantly, I would like to highlight, as discussed in the slide also by Dr. Kanaram, antibody cocktail is not useful against Omicron. That is why majority of the vaccinated people are also infected, and people who have been infected in the first and the second wave are also reinfected in the third wave. So this Casavir and Imidavir and Regin antibody cocktail is not useful against Omicron patients. So this is very important, and vaccinated people are also getting this infection. Third comes the role of immunomodulators. Corticosteroids are very useful as we all know. Then comes the role of tocilizumab, and even baricitinib is also useful if there is a cytokine storm. Then plasma therapy role has not been recommended. In second wave, we used a lot of plasma therapy, but now it has been not recommended even by the Indian guidelines and as well as by the WHO. Then comes the role of antifibrotic agents, which we have few 2 to 3% patients has developed severe lung fibrosis, which was progressive. Majority of the patients recovered within 6 months if there were sequelae. So nintedanib had a good role as well as pirfenidone. Then we have used low molecular weight heparins. Anticoagulants have a positive role, or oral anticoagulants, and many patients developed DVT and pulmonary thromboembolism. So these are also very useful. Then in the second wave, what we have learned that we need to be careful about the prolonged use of corticosteroid, as many patients developed invasive fungal infections, especially rhinocerebral ocular mucormycosis, and few patients had aspergillosis also. So that part also needs to be taken care. Then if the patient is hospitalized, then these patients need, most of the patients need oxygen therapy, which can be given best through non-rebreathing mask or a venturi mask. NRBM we found most effective, followed by high frequency nasal cannula, HFNC oxygenation, and NIV, non-invasive ventilation. And if very few patients, we were very reluctant to put them on invasive ventilator. Endotracheal intubation and lung pressure profiling safe ventilation strategies should be managed in these patients. So this is all we have learned from Delta wave. But now the Omicron is totally different game, and majority of the patients have been managed in home isolation. Few patients were admitted, and as earlier panelists have also discussed, around 10% to 20% hospital beds were occupied. 80% beds are vacant in Delhi.
Right.
So that's
and
what
about the proportional distribution, do you still see Delta cases in your practice, or it is completely overlapped by the Omicron variant?
in majority of the patients were Omicron, but a few patients, see, we don't have a genomic sequencing available in the private sector, so we have to clinically identify. But I still feel around 20% patients may be having Delta variant or maybe having Omicron with severe comorbidities. So it is very difficult to identify clinically in all the patients. Majority of the patients clinically and radiologically and with biomarkers. Biomarkers were normal, all CRP, D-dimer, LDH, ferritin, and CBC, LFT, they are coming within normal limits in most of the patients with Omicron variant, which I have seen in my clinical practice.
All right. So
and
just the last
CT
point,
is
what you
also coming normal. Yes, CT is also coming normal. There is no lung involvement in Omicron.
lung involvement.
Two patients who have been admitted in the hospital, they have very mild disease. Score is 5/25, 6/25, maximum 8/25, 4/25. Very minimal lung involvement is there in Omicron variant.
So this corresponds that the hospitalization rate is very less. So majority of the patients are managed on the no-PD basis. The
Yes.
hospitalization and the ICU required is very, very less. Well
Yes,
taken up that point, sir. Sir, Dr. Paparao, sir, Dr. Inder Mohan, sir, has towards the end highlighted one point about the biomarker. So towards the second wave, the role of biomarker, in fact, every patient who were diagnosed with COVID were asked to do biomarkers. So the current wave, how relevant you feel that the inflammatory biomarker screening?
Yeah.
And do you do biomarker test in every patient, or you restrict this biomarker testing in some selected category of patients?
Yeah, is a very important and practical question that we know most of the times what kind of variant we are dealing. As per some of the studies, some of the epidemiological studies, it is about 91% goes in favor of Omicron and 8 to 9% to Delta wave. But still, we see cases of respiratory and severe infections also. And recently, only 5 days back, one patient came with 23/25 CT severity scoring, and that should alert us that Delta is still around and still trying to access. Though Omicron is a dominant variant always tries to suppress the other variants. Still, it's not gone. Delta is also around. So in this situation, as Dr. Zenith said, it's all about about comorbidities. So whom we have to be on high alert. So those who has multiple comorbidities, particularly have a renal or a heart failure, and we are on very high alert, particularly those above the age of 60 years, whatever the variant. So this is the place where we give maximum importance and alertness, and also, to give caution to the patient not to take it light, because it can turn out to be an underlying heart failure can precipitate an underlying kidney disease, can worsen and can have acute kidney injury or chronic kidney injury. So all these are practical possibilities. So we are on high alert on those, particularly with more than 2 comorbidities and elderly people. So biomarkers has a role in this. We don't normally routinely prescribe to all on day 1. We always ask them to come on day 5 if there are symptoms of ongoing disease and symptoms of high activity, like fever is continuing, and he has persistent cough and shortness of breath, and there's a fall in oxygen saturation. Invariably, we check all the parameters, biomarkers, as well as a CT scan of the chest, a screening scan of the chest. And if we find it is more than mild disease, up to 7, we call it mild. Above 7, it is definitely moderate. We presume it is secondary to a Delta wave. And usually in Delta, there have been many studies showing that in Omicron, there's no lung involvement. It is mainly the upper respiratory, whereas lung involvement is not there, but we are still not very clear that there is no thromboembolic phenomena in Omicron. Still, some patients are coming with higher D dimers, but most of the patients have a normal D dimer, very mildly elevated CRPs and serum ferritins. And we keep an eye wherever there is possibility of progress of disease. And if with comorbidities, with the possibility that the underlying disease gets exacerbated, then we are on high alert for them. So if it is even for mild with such a comorbidities, we prefer to get admitted if it is more than above 5/25 or so, because even that much lung involvement also signifies that it could be Delta and the disease could be progressive still. So this is the time where we have to catch it up early. So these are the biomarkers will have a definite role at this point. And we see on day 5, if there is a ongoing progressive disease, then we take a CT scan and we categorize the patient and we have a treatment plan accordingly.
All right. So day 5 still finds important, especially those patients with a risk of disease progression involved. Who are
perfectly. Most of the times we have seen in day 3 or day 4, most of the symptoms subsides, except cough. In Omicron cases, except cough, most of the other symptoms will disappear. But they consistently and persistently have a dry cough. Sometimes it is mucus also. So it continues for some time, for a week or so. Even the deep winter is also prevailing now. So these upper respiratory symptoms could get exacerbated or, as per the other situations. So we should know where we have to have a high alert and where to use the biomarkers and follow up with the biomarkers as well. And that's going to be definitely useful in planning the management.
Even with the Omicron variant, though it founds to be mild, those patients with high risk of disease progression needs to be vigilant and to be tracked with biomarkers level. All right, so point well taken and noted.
So even with the milder problems, we have to have a high alert to start the antiviral drugs like RDRP inhibitors early in the disease, like, before the day 5, then it's going to have a lesser chances for progression of the disease to a severe disease.
All right, sir. Point well taken. So coming to the treatment, Dr. Zenith, sir, I would like to know how was your experience with Favipiravir, especially when we talked about your past experience, considering wave 1, wave 2, what we have seen, it was more severe as compared to the current what we have seen. How was your experience with Favipiravir, especially when we talk about the efficacy of the molecule, when it comes to clinical response, the overall number of patients roughly who had disease progression, and one point what you pointed at the start, especially those patients at a high risk. So considering this point, how was your experience with Favipiravir?
Yeah, frankly speaking, we started using Favipiravir in first wave, especially when there are risk factors. So at the onset, we were using the antiviral because it were the new at that particular point of time, and we were using in the comorbid patients. And then we saw that okay, there are no much side effects. It is well tolerated, and the patients are showing the improvement. The improvement, I certainly remember because we were running a home care program at that particular time, and we were in touch with almost all the patients daily on the daily basis, and we were checking the temperature chart of every 4 hourly that is maintained by the patients. And I remember that there was a beautiful lysis of the fever. Maybe the other panelists also may have seen that thing, that there is a like in enteric fever we have seen such a beautiful lysis of the fever like 102, 101, 100, 99.5, 99 kind of that lysis we have seen particularly in the first wave, and that prompted us that okay, this antiviral is beautifully working. It is getting the decreasing the viral load in a particular way, so that the fever is going down and all the symptoms are getting resolved. So then we started, and we also seen that if even the young patients who are running very high grade fever, they are also getting the complication at the end of the day after days or so. So then we started using in the patients who are having a high grade fever at the onset, we started using the antiviral, and then we see that okay, they are getting better. So overall in first wave this was the scenario. Second wave, we use a lot of favipiravir in almost the patients who had high grade fever, who had the comorbidities, and probably I could tell you that probably we have in that way the patients who had received favipiravir, the O2 requirement, if they had to get admitted, the O2 requirement is quite less than the ones who have not received the antivirals. Even the ICU requirement, hospitalization ratio is quite less if they have received the antiviral within the few days of starting the fever. So that was the overall experience of the first and second wave, which prompted us to tell us that okay, if the patient is running, fever is the most important symptom, I feel. So if the patient is running a high grade fever, it will tell you that okay, the disease activity is quite high, and then you have to start them on antiviral early, and especially when they are having the comorbidities as discussed previously.
Thank you. Sir, I'll come back to you again, especially to know how was your experience with the third wave. I'll come back to you later. But before that, I would like to take up a similar question with Inder Mohan, sir. Dr. Zenith has highlighted about the efficacy of Favipiravir. Would you like to focus on the safety aspect of the molecule, especially with your experience in the past two waves of Favipiravir? Right, roughly a proportion of the patient who progresses on Favipiravir or require oxygen, who are on treatment with Favipiravir.
See, Favipiravir in second wave, we have used in mild cases only, because moderate to severe cases were the proportion of number of these patients are very high. So most of these patients were admitted, and as we all know, second wave healthcare infrastructure was not good. Most of the patients were not able to get a hospital bed. So in those patients, we have used Favipiravir in those patients also. But as my experience, Favipiravir antiviral, certainly it has improved the symptoms, fever has gone down, lysis of fever was there. And secondly, the oxygen requirement in mild cases, they recovered earlier. The duration of recovery was also less in patients who were on antivirals. So most of the patients were on oxygen therapy, and we have added steroids also. Oral corticosteroids were also given, and as well as oral anticoagulants were also used in moderate to cases, mild to moderate cases, patients who were not able to get a hospital bed. So overall efficacy, and I think the molecule has worked in the second wave. And in third wave also, we have used as only in patients who had comorbidity with mild disease. Only in those patients I have advised antiviral, but the oral antiviral, the number of patients is very less as compared to the first and the second wave. So in third wave, in the present wave, only majority of the patients are asymptomatic and they are recovering within 5 to 7 days. This is my experience. But few patients who had comorbidity and they were high risk patients, we have advised oral antivirals to these patients only.
So if I want to take up that point, even if the current way we have seen mild category of patient, especially those with a risk factor of disease progression like age or comorbidity, oral antiviral still finds a place in the
Yes,
overall treatment.
certainly we should use them.
Okay, all right, sir. Point taken. Zenith, sir, just coming back to you, like, does vaccination status play an important role in deciding what therapy needs to be given to the patient? Especially now with the third wave, we have seen majority of the patients, they either have taken one shot of vaccines or they have completed both shots of vaccine. So does vaccination status decides the choice of treatment that you give to the patient? Say, for example, patient who is symptomatic and fully vaccinated, or symptomatic who is partially vaccinated or completely unvaccinated. Does this decides any treatment choice?
Um, Again, now there are enough evidence to suggest that a vaccine is keeping the patients out of the hospital actually. So even if they got the disease in third wave, they are less likely to visit the indoor hospitalization for the COVID. So that is the part which is vaccine is playing. So they are less likely to be ill. They are less likely to be in ICU. They are less likely to be on oxygen. They are less likely to be admitted. So that is the data of vaccine all over all the vaccines like our Covishield, Covaxin, the other one which are using in Western countries. All of them almost have similar kind of effects. So this is the thing which is coming up very nicely. So then the point comes is that the one who is not vaccinated, that becomes the risk factor. So now the one who has not been vaccinated by XYZ reasons, now he is more vulnerable because the others are less vulnerable. Now he becomes the more vulnerable. So again, as we have described the risk factor previously, that age more than 60, diabetes, hypertension, cardiac, renal patients, the unvaccinated herd will become one risk factor. So that is the way it will play one major role, that the one who is fully vaccinated, he is less likely to have complications. So he may not need that much of aggressive therapy and chasing of biomarkers. The one who is non-vaccinated or partially vaccinated, even I will keep the partial vaccinated as non-vaccinated only, because the one dose may or may not help that much. But yes, so partially vaccinated or non-vaccinated, we will keep it as a risk factor for the progressive disease, and we will track them more than the normal patients.
I think
So
so.
that
One
is
more
how it
risk.
changed the yeah.
So one more risk factor is added now. Currently, apart from age, comorbidity, the vaccination status of the patient also plays an important role. Dr. Paparao, sir, in just continuation to the similar question, then what is your treatment of choice in the present scenario? Especially when we talk about, there are patients who with Omicron, they are mildly symptomatic. So do you feel that the associated factor does play an important role? And if yes, what is your treatment of choice for mild symptomatic patient with comorbidity, without comorbidities, or any other risk factor as highlighted by Dr. Zenith?
Now I decide basically, visit a mild patient, moderate to severe, or severe. So it depends upon, again, the various risk factors. So as Dr. Zenith sir told that the unvaccinated is a risk factor, certainly, because 94% of the deaths in third wave is unvaccinated. It is the deaths of unvaccinated people. So unvaccinated is definitely the biggest risk factor than any other risk factor for severe disease as well as for death. So we have to keep in mind these are high risk population. So even with a mild disease, any of these high risk population, I prefer to give basic antiviral drug, particularly an RDRP inhibitor, if unvaccinated, if they fit into the indication of molnupiravir, because molnupiravir, all the trials were on unvaccinated. Actually, that has shown a good data that up to 39% they can prevent progress to a severe disease. So either a molnupiravir or a favipiravir according to the patient profile. Again, it should be elderly. They have given up all their, uh, uh, childbirth and everything, even men and women, because it can cause teratogenicity and so many. Its action on ovaries and testes, we do not know. At the same time, less than 18 years, we don't think of giving any molnupiravir. So, uh, as you said, there are about 5 million patients were prescribed with favipiravir. I also must have prescribed at least for 10,000 patients. So with this experience, I have, and clearly within 48 hours, there is a difference in symptoms, there is a difference in fever, there is a difference in energy levels. With the favipiravir, we have rich, expertise and experience with favipiravir. So those mild patients also with comorbidities and unvaccinated, I prefer to give RDRP inhibitor, either a molnupiravir or favipiravir, whichever suits there according to the situation. So moderate, I closely follow them. Depends on, again, the risk profile and severity of the, and for all moderate, I do what is called the biomarkers, initial, a baseline, as well as the follow-up on day 5, including a CT scan. So all these with moderate at presentation, we know most of the patients are mild, at least up to 90%. And you can sense what is a moderate disease in terms of clinical symptoms. So picking them and giving a RDRP inhibitor, but specifically with which we have experience like favipiravir, because molnupiravir don't have much experience. A lot of safety concerns on molnupiravir. So our preference of RDRP inhibitor is in a mild or moderate disease is favipiravir. And I prefer to use if there is a severe symptoms or ongoing symptoms to even all the moderately severe patients. Of course, severe patients we always admit into hospital and try to, as per the protocols, we give remdesivir, we give, if there is an oxygen requirement is there, if supplemental oxygen requirement is there, only we will give steroids. Otherwise, one most important point is for mild cases, uh, before the day of, during the first week, if you give steroid, and it is counterproductive, and it has shown that it will increase the viral replication and it will increase the progression of the disease, and chances of getting to severe disease will increase if you use steroids unnecessarily in the first week without any supplemental oxygen. This is most important we follow. And then we use now, if even moderate disease, we presume it is Delta, and there's chances of getting severe or more. So in such cases, we admit them, give them remdesivir, give them baricitinib, or if there is a severe disease with all the inflammatory markers very high, we, on case by cases, we decide on whom to give tocilizumab and things like that. And of course, we don't use plasma at all. And when it comes to monoclonal antibodies, it's clearly shown that I mean, the casirivimab and imdevimab, which is commonly available in India, is not useful for for the Omicron variant. And the only thing is sotrovimab is said to be effective, but though there is no clear evidence, but which is not available in India. So that's the overall, the treatment plan.
Thank you, sir, for that elaborative explanation. In fact, that also covers the question from the audience. Someone has asked that how is the overall treatment algorithm in the current wave of COVID-19? Thank you, sir, for beautifully taking up that question. In the moment, sir, I would like to highlight that one point what Dr. Paparao has highlighted. So when we talk about the oral antivirals, the recently introduced molnupiravir, some of the safety concerns we all have came across, especially when we talks about the mutagenicity, genotoxicity, need of prolonged contraception. So are this point really relevant in the clinical practice? How relevant are they? And where you will restrict the use of this antiviral drug?
See, as we all know, we have two oral antivirals which are available now. One is the Favipiravir, the safety profile, etc. We have all discussed about it. The second oral antiviral, we all have a very less experience. That is molnupiravir, which is basically a mutagenizing agent, and it causes increased frequency of viral mutation and lead to error catastrophe and stops the virus multiplication. And it also acts on RDRP, that is RNA dependent RNA polymerase, and it causes mutation in G2A, that is guanine to adenosine, and cytosine to uracil. So that concern is there. So that is why molnupiravir is not recommended for children or age group less than 18 years. Then it is preferably should not be given to men and women both who have chances of childbearing in near future. So if these two groups, major groups are excluded, then we have a very limited population. So at present it is indicated in patients with the moderate to severe disease or mild disease who have a chances of progression to a severe disease with at least one risk factor. Only these patients it is recommended. Secondly, then if molnupiravir is recommended, then contraception should be practiced for at least 3 months from the last dose. So that is a long period. So we need to discuss this and factor with the patient whether they have any plan for childbearing. And secondly, since it's got its mutations, mutagenizing agent in the virus, it may cause mutations in the humans also. So it may have implications in the teratogenicity, carcinogenicity, although more studies are required. At the other hand, we have a good experience with Favipiravir, and safety profile is also good. So preferably in those patients, we can use Favipiravir, and in few high risk or selected patients, we may use molnupiravir, and maybe more and more data will come, and only the time will tell how safe the molecule is.
Dr. Zenith, sir, any comments from you on what Dr. Inder Mohan has already highlighted about molnupiravir? Do you feel that the concerns that are being highlighted are of real importance in the clinical practice?
Basically, I feel molnupiravir has only one thing which is can be focused, is that it has no renal modification. So the only one sub-segmental area where there are risk factors, where there are no fertility concerns like age more than 60 or something, and the one who are having borderline renal failure, they are the ones area where molnupiravir can be tried over favipiravir. Otherwise, I feel that the overall experience with favipiravir is rather more encouraging than molnupiravir in almost all the subsets when we compare head to head these both oral agents.
So, in continuation to that, how is your experience with Favi in the current wave? You have already highlighted how was the experience in the first and the second wave. especially knowing that, as you said, that very less number of patients needs hospitalization. We also need to consider patients with a risk factor of disease progression, comorbidity. So how is your experience, especially with the current wave, the Omicron variant?
Practically speaking, we are using one or more than one risk factor. We are giving them the antivirals. That is the basic this thing. And secondly, even when there are no risk factors, young patients, what we do is if they are having a high grade fever, we chase them with the biomarkers. And if they are going high on the biomarker front, then we may like to add antiviral on these patients. And because we don't have a genetic study readily available, so as I said in the beginning, that the only concern revolves around that is it a delta. So we had to catch the delta early and start them on antiviral as early as possible.
Dr. Paparao, sir, any comments from you? Similarly, how is your experience for Favi in this wave?
Yeah. Favipiravir, first, actually, more than 90 to 95% of the cases we see now, they are all very mild and doesn't deserve starting antiviral drugs early and so on. But where the whole thing revolves around comorbidities and possible risk of progression to a severe disease, and we have to catch them early, start them on antiviral drugs, and of late, we almost stopped giving molnupiravir for the safety concerns. As very special population, like above the age of 60, who has given up childbirth, everything is over. Then for them only, possibly, if there is a renal disease or cardiac disease, and if there is moderate disease, they are the very unvaccinated. They are the very small, narrow window that we have for molnupiravir. Otherwise, we have completely seen the safety of favipiravir. And another oral antiviral drug is Paxlovid, which has a very good data actually, and it's not available in India at this point. If it comes, possibly it could help more and more people.
All right, all right. So can we take up this point, sir, even in patients who are mild symptomatic, especially those associated with the risk factor like age, comorbidity, oral antivirals plays a very important role. Rather than giving symptomatic treatment, these are the set of patients we can consider giving oral antivirals on the OPD basis.
Definitely, most of the patients are treated as outpatients only. And another important point is, and most of the patients doesn't require antibiotics. Actually, secondary infections are very, very less compared to even common cold in COVID. So it is unnecessary to give routine antibiotic unless there is a there is a special symptom or rise in a TLC or rise in procalcitonin, etc. Then only if there are specific pointers, then they deserve giving antibiotics. Otherwise, routine antibiotics are not required. And possibly, if there is any slightest chance of getting it, worsened disease, like elderly population, more than one comorbidities, I think it is best treated like favipiravir as early as possible, and also alongside the symptomatic treatment.
All right, sir. Point well taken. Last question for the panel discussion, Dr. Inder Mohan, sir. One of the practical thing that we all have experienced, that those patients with COVID, especially post-COVID fatigue and myalgia, is something which stays with patient for quite a long time, especially weeks after, even after COVID treatment we have seen. So is there any experience that those patients who were treated with oral antivirals during their COVID treatment, the incidence of myalgia or the incidence of fatigue after the completion of treatment is relatively less as compared to those patients who were not given oral antiviral? Is there any evidence which we have seen for fatigue and myalgia?
Yeah, I think I have searched on the net also for this, but and in my personal experience also. So oral antivirals most of the time in second wave and now here also in the present wave, very less patients in the third wave we have used oral antivirals as discussed by the eminent panel, and in second wave only in mild cases oral antivirals were used. So what I have seen that the fever has subsided, duration of treatment was less, and there was less hospitalization in these patients. Oxygen requirement was also less in these patients. Recovery was good. But personally, I have not seen any change in the post-COVID syndrome or long COVID symptoms in these patients. Because majority of the patients who have developed the post-COVID syndrome or long COVID symptoms have been only those who had moderate and severe disease. These were the patients who have developed post-COVID complications up to 6 months, and around 2% patients of the severe disease, 2 to 3% patients had developed severe progressive fibrosis. That is what, and majority of the patients have recovered within 3 months, and around most of the patients recovered within 6 months, and only 2 to 3% patients have developed progressive fibrosis. That is the only complication which I have seen in these patients, and they have also now behaving well and are on off oxygen. This is my personal experience. As well as fatigue and myalgia are concerned, I have not seen any difference whether we have used oral antivirals in those patients or not.
All right, sir. Considering the mild nature, maybe the post-COVID syndrome will be relatively less with the current variants that
Mild
we
patients, I have not seen
not
post-COVID
exactly.
or long COVID syndrome in these patients.
All right, sir. So thank you so much, everyone, Dr. Paparao, sir, Dr. Zenith, sir, Dr. Indermohan, sir. I'm sure the audience, those who were attached for this panel discussion, would have definitely been benefited, especially all the holistic approach you all have cleared about the current treatment management. So Dr. Kanaram, over to you.
Thank you so much, Dr. Sagar sir, and for beautifully moderating this session. And thank you so much again, Dr. Paparao sir, Dr. Zenith sir, and Dr. Inder sir, for joining today's panel discussion and sharing your pulse of experience in both previous wave and the current wave, with or without the antiviral use. And you also shared the what things guide in treatment decisions, so that will help our audience to decide their treatments for those respective states of patients. Thank you all of you again. And there were some questions in the from the audience, but all questions were taken by Dr. Sagar sir and answered by all panelists. So we can again thank you all. Thank you, Sagar sir.
All right.
Thank you. Good evening.
Thank you.
Thank you.
Good evening. Take care.
Okay.
Same
Thank you,
sir.
everyone.
Good night.
Good night, sir.
Thank you very much, doctor.